Welcome to the MIDAS webinar series today. We'd like to get started. I am Wilbert van Panhuis. I am of the MIDAS Coordination Center, and we're doing the MIDAS webinar every last Friday of the month. We've done a few webinars already now, and we just keep moving forward into the future. Just for those of you who may not be familiar with MIDAS, it's a global network of infectious disease modelers focused on dynamics of infectious diseases. Of course, a lot of MIDAS is working on COVID-19 right now. There are over about 500 members at the moment, and the network is still growing. If people are interested to become a member of MIDAS, they can go to the website, midasnetwork.us, and fill out the member request form, and then we will process it. The webinar is being recorded as of now, so just so you're aware, and the recordings will be posted on the MIDAS website. Also, before we begin with today's webinar, I'd like to mention that on Monday there will be a webinar organized by NOAA. We've been working with NOAA to improve the use and value of climate and environmental data and Earth observation data for infectious disease modeling. And they are going to present the different opportunities they have for help with using their data and their data products. So I'll post in the chat the link to that webinar announcement if you're interested to join that on Monday. Now it's my pleasure to introduce our speaker today, Dr. John Drake of the University of Georgia. John is the director of the Center of Ecology of Infectious Diseases at the University of Georgia. He's also the Distinguished Research Professor of Ecology in the Odum School of Ecology at the University of Georgia. And his research seeks to understand the dynamics of biological populations and epidemics, focusing on bringing experimental and observational data together with mathematical theory. His current projects are about dynamics of Ebola virus in West Africa, spread of white nose syndrome in bats, also the proliferation of SARS-CoV-2 virus in the United States and globally, and the development of the theory of infectious disease, early warning systems, and infectious disease intelligence. John holds a PhD from the University of Notre Dame and has been in Georgia since 2006 at the University of Georgia. So I'm very happy that John is going to present for us today. Also, John is the chair of the MIDAS Steering Committee, and we're very grateful for his time in that role to help us as a coordination center to do what we can to meet the needs of the MIDAS network. So with that, I'll stop sharing my screen and I'll invite John to share his screen and start. We have if you have any questions during the talk, please put them in the Q&A. And then if John sees the question, he may answer them. If not, then we'll wait until the end of the talk. Okay, stop share. Okay, John, thanks a lot.
All right, good afternoon, everyone. Well, good afternoon to those of you in the Eastern time zone. Good morning to those of you in Central and Western time zone. And hello to everyone else where I don't know what time zone you're in. Wilbert, thanks for the invitation to speak. Do you see my slides properly?
Yes.
Very good. So what I wanted to talk about today is a model that we've been working on for understanding transmission of SARS-CoV-2 in the United States. This is work that's come out of a working group, the CEID Coronavirus Working Group, which we formed in January 2020. In the center, we invited students, faculty, staff, anybody who was interested in following what was then an emerging outbreak to join us. And over time, our activities have proliferated to greater than 30 projects and many dozens of people. Of course, most of these are student projects, and one of the things that I've found in these unexpected times is a great opportunity to introduce students to mathematical epidemiology, to thinking about the way in which science and societal activities interact, and just to generally engage scholarly work with what's going on in the world around us. I'm pleased to see in the participant list many old friends have decided to tune in. Thank you for doing that. I also see lots of names I don't recognize. It's sad that this year we haven't been able to hold our usual meetings and conferences, but I hope in the future to get acquainted. And if you think that some of our work might be of interest to you, I urge you to reach out. Our center's website is ceid.uga.edu. And on the screen here, I have a link to some of our COVID-specific work. The working group has, as I said, engaged in a wide variety of things. Some of the things that are publicly available are our work on spatial models to try and understand the spread. We, like many other groups, have developed an interactive data tracker that allows users to query data for the US down to the county level and manipulate that in ways to make quick judgments about the state of the epidemic. A non-parametric nowcasting algorithm that we use to try and bring our understanding of transmission and particularly case burden up to date to the current time, recognizing lags in reporting delays and case reporting error. The project that I want to talk about today, though, has to do with the development of a stochastic dynamical model for understanding spread. This has been a fun exercise and one that I hope is also useful. We've seen in this webinar series and through many, many papers and presentations over the last 6 months, a wide range of models developed by different groups. And this is our contribution to the fray. I think some of the things that distinguish our model will become evident in the course of today's presentation. But our model is not a silver bullet either, and possibly isn't, I don't claim it to be the best model that's out there. But it's different, I think, in a couple respects to many models that have been presented. It's also a work in progress. So there's problems with this model that we haven't disentangled yet. And to me, one of the intellectually most stimulating things has been working through those challenges and thinking about the ways in which the knowledge gained in this exercise may be useful in the future as well. We developed our model originally for the state of Georgia. We were looking at data that were coming out of our own state on cases, hospitalizations, and deaths. And especially we were trying to understand in March and April the consequences of policies and individual activities, what the consequences would be for transmission. Since then, we have tried to expand our model to include all 50 states as well as the territories of the United States. And we continue to look at various scenarios for thinking about social distancing policies and increasingly other sort of distributed methods for trying to reduce transmission, things like queue spacing in grocery stores and mask wearing in public, that kind of thing. Some of the features of our model: it's a stochastic transmission process that also includes realistic random variation in the observations. We include realistic distributions for the pre-symptomatic and symptomatic periods, what in the literature is sometimes called realistic waiting time distributions or interval times. This is something that we thought at the very beginning might be quite important based on right-skewed distributions from case notification data, case investigations. I think that increasingly we're seeing models that include this feature. Increasingly, I'm wondering whether or not it's actually necessary, as some of the mean field models have actually been quite effective. But nonetheless, that's the model we're working with. We have different transmission rates for asymptomatic, pre-symptomatic, and symptomatic individuals. We allow for time-varying case diagnosis and probability of case detection, particularly reflecting access to testing in the United States over the time period from May to July. We think that human activity, mobility, and interactions are probably some of the key features that help to curtail transmission in the late spring. And so we use data from the Unicast Corporation to model human mobility. We don't have a particularly sophisticated way of doing that. I'll tell you what we're doing in a little while. One of the things that we hope to do in the future is to understand in greater detail the relationship between individual mobility and policies that are intended to affect that. The current version of our model includes a latent process to capture the effect of environmental factors. I think it's still an open question, the extent to which the absolute and relative humidity of the environments that people are exposed to, indoors and out, affect the viability of the virus and its persistence on surfaces, and therefore translating into transmission. But of course, there's also a question about how the weather patterns affect individual movement behaviors, in particular time spent indoors, and how that relates to transmission. Personally, I believe that face mask use is one of the most effective means we have for control, but we have very little data, particularly longitudinal data, on the adoption of face masks in the population. And so this is another one of the features that, that our latent process is meant to represent. As a result, our model belongs to a group of models that I refer to as semi-parametric, drawing on some research of Simon Wood from the early 2000s. Basically, the idea here is we have dynamical systems, SIR models and their extensions that we use for expressing our ideas about how we think transmission happens. We can estimate parameters of those models and perform inference very often, but that inference is only as good as the representation of the transmission process itself. There's a great deal of heterogeneity, I believe, in the way in which SARS-CoV-2 is transmitted. That's a feature of spatial variation, differences among populations, communities, counties, states, differences in policies, but also things like large-scale differences in behavior patterns, where now we currently see younger people contributing a greater share to transmission than previously, or even larger factors like supply chain that then affects the availability of testing reagents and the time between sample collection and the test result. So a semi-parametric model allows us to fit those parts of the epidemic in sort of a black box component to a parametric model, while at the same time capitalizing on our mechanistic understanding of how transmission happens. Then the last thing is that in order to provide as useful information as possible about the conceptual value of different kinds of interventions, we've also considered a range of possible responses. Things like improving case detection, faster detection, and especially policies that affect mobility. This is one of those situations where I think our model shows what's possible, and the extent to which it shows what's actually going on, I think will require considerable more research before we can be fully confident. Nonetheless, I think that, that these exercises can be very useful in understanding how it is that transmission is occurring and what the options for containment are. The interventions in particular that we've looked at are reduced, or now it seems like increasing mobility. The plot in the top left here shows a trace of some spline fits to the unicast data that we've been using. We consider these to be basically a coefficient or a factor that reduces the amount of transmission from person to person by a time varying fraction. Of course, this doesn't change the transmission within households, for instance, but we think it may actually represent a significant amount of the community level spread. Decreasing time to diagnosis, improving time to detection, these are also some of the factors that we allow to be time varying. In this case, because we don't have any independent data streams, we suppose that they're monotonic. We propose parametric equations to represent the speed at which those change, including things like the minimum and maximum values, and some of those parameters are fit in our fitting process. In a nutshell, this is what the model looks like. I think at last count there were something like 17 stages, but the key bits are there's a susceptible population. There's a latent incubating fraction, which can also transmit, so contributes to the force of infection. Infections are characterized as those which are asymptomatic and never display symptoms, symptomatic and never become detected, and symptomatic and at some future state will become detected. Those that become detected progress to be diagnosed cases. There's a time lag there as well. Diagnosed cases may recover, they may be hospitalized, and hospitalized cases may recover or succumb. And we've done some further analysis to try and understand how all of these different processes contribute to transmission. In particular, our force of infection is based on both a baseline force of infection, which is an estimated parameter, we'll call that natural transmissibility, a noise term, the effective mobility, which is time varying on a daily basis according to the unicast data by state, and also the latent trend, which is also time varying, smooth, and fit for each state individually. The force of infection is parameterized in terms of fundamental rate, which is based on the symptomatic detected individuals, and then modified according to other classes that also may contribute to transmission, but at a different level. To give you a better understanding of our latent trend, and how that contributes to transmission, I said both the latent trend and the mobility act as a factor to reduce or increase transmission from baseline. The mobility, there's a trace there for the mobility for one state. And then the latent trend is a smooth fit based on some spline coefficients, and I think around 10 basis functions or so. We've played with the model quite a lot to try and find something that is both suitably flexible to account for the fluctuations that, that seem apparent in news reports and other information about the ways in which behavior is changing, but also smooth enough to allow for some extrapolation and consistency over time. The mobility trend and the latent trend are multiplied together, and that gives us a factor. Here you can see what that factor looks like for the state of Alabama. And, you know, roughly speaking, early March, pre-lockdown, we had a baseline mobility. When shelter in place and other policies went into place, mobility was reduced. I think this is the primary thing that that resulted in a reduction in transmission during the middle spring. But then there was an increase in mobility, which is consistent with what we've seen across the country. How low mobility got and how quickly it came back is something that differs greatly from state to state. The latent trend lagged somewhat the mobility trend. I think the latent trend particularly includes things like face mask wearing. But you can see now the combined trend basically just is the latent trend, because the mobility trend has gone back up to 1 with the relaxation of social distancing requirements and shelter in place orders and things like that. We've done some additional calculation using the next generation matrix to look at the effective reproduction number. In this particular version, it's expressed in terms of the number of susceptible individuals, and allows for us to look at the contribution and therefore the sensitivity of a number of our features, such as the diagnosis rate, the fraction hospitalized, things that might be considered control parameters that we have some effect on. Model fitting. This has been perhaps the most exciting part of the whole project. Initially, when we started, the model fitting was relatively straightforward. We were working on fitting just to the state of Georgia, where we had a lot of both published and unpublished information about case reporting, what the lag times were, what the investments in testing were, that kind of thing. We knew, as was true for across the country, that there was tremendous underreporting At the time, I thought that the ratio was probably 10 to 1 or greater. And so we developed our model so that it would be fit both to observed cases and observed deaths, with the idea that the death data might be a more reliable representation, but considerably lags behind the reported case data. Our model is implemented in the R package pump, which allows us to readily generate stochastic realizations of the model, to fit the model using a variety of fitting procedures, and to modify the observation process as we need. Our current fitting procedure uses particle filtering. This is a way to approximate the maximum likelihood estimates of parameters. The parameters themselves are allowed to take a random walk, and this, as well as the filtering process itself, allows us to search a large space of possible parameters, and is proved in the limit to converge on the maximum likelihood estimates. The parameters that we're fitting are the baseline transmission rate, the fraction of hospitalized cases that result in death, the process noise, which we found to be quite important, the dispersion parameters of the observation processes, the initial size of the latent infectious class, as well as the spline basis function parameters. The other epidemiological parameters, things like the recovery rate, are estimated from individual case investigation data from various published sources and combined for the purpose of this process. As I say, this has been one of the most exciting parts of the project. That's because we found it tremendously difficult to test or to fit. I think that there are some of you that are fitting similarly complicated models, and one of the things I'd be eager to do in the Q&A afterwards is compare notes about what kinds of problems you're running into. We're doing what we can to effectively explore the parameter space, but as we've scaled up now to trying to fit to all states and territories, that's been quite difficult. We update our analysis on a daily basis, but even using the high performance cluster, it's not possible to troubleshoot for all states at all times every day. And so we're trying to develop better methods to stabilize what our parameter estimates are. We're also finding that our estimates do vary a bit from day to day, and also at longer timescales. The day-to-day parts, we believe, are due to key parts of the data series being particularly influential, like, for instance, the early parts of the data series. The long-term fluctuations, I think, have more to do with changes that are not well captured by our parametric representation of the process. So, for instance, the accrued case fatality rate has been declining dramatically since the early summer. My belief is that one of the primary contributors to that fact is age-associated behavior change. I think that the highly vulnerable classes have, because of infection control procedures in things like places like hospitals or nursing homes, or in the community, just people's personal choices about social distancing, are still remaining largely outside of the transmission loop, but that younger people are increasingly represented in the infected cases, whether diagnosed or not. As a result, the case fatality rate is going down, but our model doesn't currently have a way to represent that, and so, of course, is trying to twist itself in different directions in order to account for that gross feature of the epidemic. That's something that we're working on right now. Model assessment. Here's just a brief overview. I show the mean absolute error by state ordered by the error on reported cases. This is based on the difference between simulated and observed data after smoothing to account for the weekly periodicity that's been observed by many groups. We use 100 trajectories from all parameter sets that are within 2 points of our maximum log likelihood. We calculate the MAE for each data point across simulations and then average over the time series. And so you can see basically what we have is a lot of states in which we think we have reasonably good fits. Just ballparking it, I would say 45 out of 50 on any given run we will feel are quite strong fits, but then a couple of anomalies. Obviously, contributing to mean absolute error is the fact that some of these states have seen more cases, and since we're not looking at the squared error here, that inflates what the error is, so that maybe accounts for California, New York, and New Jersey. And we do believe that most of our poor fits are actually not based on a poor representation of the transmission process, but a failure to find good parameters based on the fact that we've tried to automate parameter fitting for all states simultaneously. Here's an example of a good fit of the model to the observed data. The blue curve shows the number of daily cases and daily death reports in our state, the state of Georgia. The black curve shows the mean of those different maximum likelihood estimates. And the gray envelope at the end shows a projection. I think that this particular run was made on July 23rd. But the same state at a different point in time, we might have a poor fit, which we believe is due to a failure of our optimizer and something that we're not able to troubleshoot in real time. Another state that's been in the news lately, we can see the resurgence in Arizona, well captured by our model, as well as what appears to be an average decline over the last couple of weeks. And in the, most of the data that I've seen, this looks roughly like something like a stabilization over the last 2 weeks or so. Forecasting. So we have just begun to use our model a bit to try and project forward. Our projections are at most 6 weeks ahead. This requires, because our model is fit to a latent process, which itself is fluctuating, as well as a mobility process based on observations, but of course we don't have those observations for the future, requires some level of conjecture. So here's how we've done it. What I'm showing here is that transmission rate modifier for all of the states and territories over the entire time from the beginning of the epidemic to the present, and the blue curve shows an average among these. What I think we roughly see here is a decline in transmission, which is largely initiated due to a change in mobility, and then, roughly speaking, stabilized transmission. I don't mean that the curve is flat, I mean that the transmission rate is roughly constant on average over the country due to face masks, queuing policies, individual behavior, things like that. Of course, you see there's quite a lot of variability from state to state. The scenarios that we look at are a return to normal, which means that human mobility ramps up linearly from the present time to 100% of what its baseline was, that this ramping up occurs over a period of 7 days. What we call maintaining social distancing, which is just to say whatever level of human mobility is being practiced right now, that persists into the future. And then increasing social distancing, which has that the human movement level ramps linearly from the current level down to 30% of baseline. That 30% level being taken from what the minimum observation was in New York City when transmission declined there in the late spring. And I believe that's the maximum reduction at a state level that we've seen within the data that we're looking at. So something like the theoretical maximum reduction in contact based on what is possible with policies and behaviors exhibited by US population. The latent trend is a little bit more complicated. One of the things that we've found is that because of using this spline basis for the latent curve, the most recent observations are quite variable. So high variance there based on a lack of constraints outside of the observation range. And so extrapolating our latent trend forward, basically what we say is, well, let's consider the last 30 days as being representative of what things like individual behavior, queuing practices, and face mask use might look like in this state. But we'll cut off the most recent 10 days because that's overfit and not well constrained. And so we just take the mean of the 20 days preceding the last 10 days and we ramp up or down to that level and propagate that forward as being our projection of what the linear trend or the latent trend might look like into the future. I've finished describing the model, and so I'm going to answer a couple of questions that came up. The first question is, did you add any corrections for states where distance may not be directly correlated with contact? No, we didn't. We don't have a good data stream whereby to account for state-to-state differences. And so, in fact, we're fitting the same model to all states, but fitting each state independently. So for those of you who are familiar with, for instance, econometric fitting, we're not doing any panel estimation where information on parameters is shared across states. And the only state differences that we have are those that are based on the data, differences in reporting of cases and deaths, and that includes covariate data, which is differences in measured mobility. Another question is, are populations stratified by demographics, health status, behavior, and spatial distribution? There's no stratification within states for spatial distribution. There's also no linkage between states for movement of infected individuals reinfecting places where perhaps there's little transmission, although my opinion is that the vast majority of transmission right now is based on locally acquired infections. In terms of demography and health status, we have not built that into the model. For a while, we were pursuing an approach that would allow us to downscale or apportion our case data according to demographic features of the state in order to generate things like predictions of hospital demand and deaths, but we have not pursued that recently, and it's not dynamically part of the model as well. Another question asks whether our observations assume no asymptomatics or mild cases. We do assume that there are asymptomatic and mild, unhospitalized, and completely unreported cases. They don't contribute to our data. What fraction of infections are reported is part of both the observation process, which is FIT, and the parametric process for diagnosis, which is based on a parametric representation of the increase in the availability of tests. But we don't include, for instance, tests performed as a covariate in the model itself. I'd like to move on in the last few minutes to talk about what some of our results are. And hopefully to be able to share some of our methodology with some of you as well in the near future. So this is based on our July 23 run. One thing that we did just in order to get a snapshot of what's going on across the country, we looked at the number of states for which observations were shown to be greater than 100 cases per 100,000 per week. We find that 28 states are forecasted to be in this so-called hot zone. And we asked the question of what could be done to contain that. What I show here are just the top 10 states. In each case, our model suggests that increased social distancing to the level that was accomplished in New York City in the late spring would result in bringing all of those states below this 100 cases per 100,000 per week by September 3rd. But in most cases, that is to say, most other cases, that is to say, human mobility trends and other protective measures like mask use continuing at the present level, we don't predict there to be significant leveling of the epidemic curve. In order to make these results more useful, we have developed an interface that allows one to query the model output. So users can select a state, mobility scenarios, adjust various data outputs, look at things like cases, deaths, total number of infected individuals, which includes the asymptomatic and pre-symptomatic individuals that are not represented in the data, and explore the data output. This is something that, so I should mention that we have not published any of these results yet. I provided a website earlier which has some of our results, but none of these model results are presented there, and that's largely because until we can become confident with our automated fitting scheme that allows us to fit all 50 states every day, we're reluctant to publish the results. Further things you can investigate, looking at the effects of latent trends and individual mobility scenarios state by state, and then of course aggregating across all the states. A quick dip might show us what some of these states look like. So first we can look at daily cases and deaths per 100,000 of population. The state that we know best and think that we understand best, here's a projection for Georgia through September 3rd. The model projects an increase in daily cases and deaths under both return to normal mobility and maintaining social distancing. Georgia's been in the news lately for some of our policies. For us, there's little difference between these two scenarios, and that's because basically the state of Georgia has fully reopened. But we also find that shelter in place similar to what we had in March and April of this year would be effective at reducing the R effective below 1. Here we look at some data on the total number of infections, including unreported infections. This is forecasted to increase dramatically under the two higher scenarios, and just reflects the fact that we believe that there's still a large fraction of unreported infections within the community. Another example, Arizona, under return to normal in Arizona, we think this would be similar to the state of Georgia. However, its status quo suggests maybe being able to maintain the current level of transmission. So recent measures in Arizona, including behavior change, possibly reducing that R effective to around 1, but not much below it. Of course, again, increasing social distancing would result in a reduction in transmission and containment of the outbreak. Here's an example for Arizona showing the total number of infections, not just those that are reported, so all of the latent and pre-symptomatic infections as well. I think the news from the last couple of days has commented on a possible geographic transition and resurgence in the Midwest. Here's an example from Illinois. Our model suggests that transmission strength has been trending up over the past few weeks, which explains that resurgence. Although cases have begun to creep up, our model predicts a significantly larger increase in the next 6 weeks. Like Georgia, there's little difference between the top two scenarios, the return to normal and the maintaining social distancing. But there is a significant difference to increasing social distancing. New Jersey, where containment activities have been more effective, like other northeastern states. Here the model suggests reopening might be possible without triggering a dramatic resurgence, at least in the short term. But since these scenarios are defined on the basis of human mobility, this is contingent on other measures like face mask use continuing to hold transmission down. It has become customary to present results in terms of cumulative impacts on cases and deaths. So we've provided a couple of plots there. Georgia, like many states, is continuing to see that increase in cumulative cases. There is a small difference here between normal and maintaining. And I think it's important to note that the difference between where we are now at something like 160,000 reported cases and the total number of cases, even if we increase social distancing dramatically as predicted, is still pretty considerable. And so difference of maybe 40,000 cases and many hundreds or 1,000 deaths as well. The same plot for the state of Arizona. Here, the status quo mobility is expected to result in fewer cumulative cases, and that's because our latest models show flatlining of the epidemic there. And here we have in New Jersey, seeing very few increases in the cumulative case count over the last month and a half or so. And we anticipate that under conditions there, if they remain the same, the pandemic will continue to be stable. Very briefly then, in the last few minutes that we have, some conclusions and takeaways. Our model projects that the adoption of increased social distancing could significantly reduce the impact of the pandemic throughout the country. I'm sure that's not a surprise to this audience. I do think that there's more to be learned by partitioning the effects of social mobility in a more fine-grained way, and also by trying to understand better these alternative distributed methods we have for containment, things like rapid case identification and contact tracing, face mask use, limiting aggregations of people, and so forth. Many places have already returned to normal mobility. I think that that means that behaviorally there's room for improvement. We can do it if we choose to. And at all stages where we are well before saturation of infections, where susceptible depletion starts to act, of course, the earlier you intervene, the more effective it is. I do think it's possible that some states can proceed with opening without risking a major resurgence, but I do not think that that is generally true. As a scientist, perhaps some of the most interesting findings have been the challenges that we've encountered in trying to fit these models. When engaging in an exercise like this, one's never sure what the right level of complexity is and what's fittable or learnable and what's not. We think that the epidemic has changed its behavior considerably between the spring and the present time. And that means that stationary models that assume that parameters are the same, that behaviors are the same, will never be effective. If they get the curve right, they get it right for the wrong reason, which is really poor for extrapolation and forecasting. And so we've tried to combine learning from data together with domain knowledge, which comes from things like case investigation. We're finding that challenging, and particularly the high dimensional estimation has been particularly difficult. We think that we have relatively reliable estimates of parameters, but we know out of any given batch, some of them don't turn out right, and we're trying to come up with routines to check that and improve our fits automatically, so they require less manual tuning. In particular, the MIF algorithm occasionally produces very bad model fits. We think this is by converging to local maxima. We're interested in finding ways of linking this with, for instance, stochastic methods like genetic algorithms, simulated annealing, or possibly grid search, although grid search would currently be computationally prohibitive for us. And we're planning to implement in the near future something we call context-aware parameter initialization, which means that we want to use information from prior modeling exercises, not just the prior data, in order to initialize our automated fitting on a routine basis. And continuing to try and interpret the results of those parameters correctly. As I mentioned briefly earlier, we think that the changing case fatality rate, I mentioned this as the crude case fatality rate, not meaning to imply that, we have knowledge about how the infection fatality rate has changed. We think that this is related primarily to behavior, and in a way that our model is not demographically structured. So because we have no age classes, for instance, in our model, there's no distinguishing between younger and older populations. Our first approach to trying and solve that problem will be to include a time-varying function for the case fatality rate to allow the model to separate the fitting of death data and case data, and then also seeking to improve our optimizer. So all of the heavy lifting on this project has been done by Andreas Handel, my colleague at the University of Georgia, and Andrew Tredenik. My contributions were primarily to creating the structure of the model in the first place and developing the Georgia-specific model. But this extension to the 50 states has required much more effort than I could perform on my own. So I'm very grateful to them for that. I'd also like to recognize two people who aren't named on the slide. Eric Marty, who's helped with all of our data visualizations, but also has, I think, very deep insight into the ways in which our model has been informed by the data that we have available to us. And Eamon O'Day, who is a postdoc in the group and has contributed a lot to the mathematical analysis as well as troubleshooting the fitting. So I'm thankful to them, and also to the NIH. When we started this work, we were supported by a MIDAS contract that's since lapsed, but we're very happy to continue in the MIDAS network and sharing our results with everyone. Thank you all.
Thanks, John. Thanks a lot for a great presentation. A lot of work that you showed. Maybe if there was a fair number of questions in the chat, but also if people would like to ask a question, please raise your hand in the participants, and we will unmute you so that you can ask questions. But maybe, John, you could start with some questions from the chat, and then as people raise their hands, I'll unmute them and allow them to ask questions.
Happy to do so. One questioner asked what basis functions are used. And so I am going to defer that and other detailed technical questions to the fact that our model is changing and we have been tweaking things from time to time, and I don't recall all of the details, and I don't want to misrepresent what was presented here. One of the practices that we've adopted in our group is that when we post to our website, that was listed on the first slide here, we are trying to link as much documentary information as we can. So that might include preprints or more often links to GitHub to allow the scientific community to access both our methodology as it was at any point in time in the project and the form that that's being presented at that particular time.
Thanks, John.
Another
Sam
question.
has a question. Sorry, I interrupted. Sam has a question, and he can talk now.
Hi, this is Sam Shiner. You talked about incorporating, other models and their results. I'm just curious, have you compared your model results with those of others just to see how similar or different they are?
We have not compared it in a formal way, particularly the models that the CDC is reporting on. We try and monitor what their performance is and what their predictions are to try and figure out things like, do they know something we don't know? But no, we haven't formally presented them in that way, and we are not formally contributing these predictions to any of the forecasting operations that are going on right now. And partly that's because, so they were initially designed to do so with the 6-week case and death prediction targets, but having not been able to stabilize our automated fitting process and not having the bandwidth to troubleshoot the remaining 5 states on a daily basis, we haven't felt that our results were reliable enough to distribute in that way. I'm sure that there will be a retrospective after this is all over, comparing the performance of different models at different times. I hope we might be invited to participate in that, even though we haven't been timestamping our predictions. I'll also mention a couple of other things. We have a couple of other projects which are more specifically focused on forecasting. This project has a forecasting component, but it's more about developing a parametric model to represent transmission, and really using that in order to provide something that might be like model-informed situational awareness for decision-making. So, we spent a lot of time trying to figure out what's a reasonable way to represent the effect of mobility and the effect of face mask use, and can you partition those things? So because it doesn't have that forecasting goal specifically in mind, that's not what this model was for. We have some statistical models for forecasting. And in particular, we've been participating in county level forecasts that are part of the DoD ILI COVID project that I think some of you are probably aware of. And in that exercise, our performance is quite strong. However, that's not based on a parametric model, it's based on a statistical model. So all it can provide is short-term predictions, and it doesn't provide any insight into what you can do to turn the curve around.
Thanks. Erin, you want to ask your question?
Yeah, thank you very much, John. That was really interesting. I was curious whether you've dug into the estimated dispersion parameters that you use for the negative binomial functions that control how the cases and deaths data go into the model. And in particular, can you interpret something about how strongly cases versus deaths versus mobility are informing your transmission parameters?
Yes, and it's a good idea. So the yes part is, have we dug into that? And we did that in, I think, around late June. And this was a time when we were where we were very concerned that our over dispersion was not sufficiently capturing what I'll call the medium term fluctuations. And so this included both observation error that was periodic and predictable, and sort of lags and catch-up times as diagnostic results came in and that kind of thing. At the time, we weren't interested in partitioning our model fitting to the different sources of information. That's what I think is a good idea, and we should put some effort into that. We were mostly interested in making sure that we had the best and most informed model fits. The other thing that I'll mention is that in the state of Georgia, we're also reporting daily hospitalizations. And so we've structured our fitting routine to fit to hospitalized data as well when those are available. But for the majority of states, we don't have those on a daily basis. And so fits are only based on cases and deaths. I have another question in the chat box. How do you link mobility decrease and contact decrease? For example, do you assume 30% decrease in mobility accounts for 30% decrease in contact? Yes, so that is what the model assumes, but we don't believe that actually captures the way in which person-to-person transmission is occurring. And our fudge factor for that is the latent process. So from my own grocery shopping and things like that, my observation is that there are a lot of people in my community who are practicing social distancing on a microscopic level, by which I mean they maintain social distance in public settings. And I think that that's substituting for the social distancing that was enforced by shelter in place in the late spring. The idea in the model is that we don't have a parametric way we don't have a data stream on how much that's happening, right? We don't have a data stream on, how many face mask wearers there are at Lowe's or Kroger. And we don't know what that substitution of what I call microsocial distancing is for the effectiveness of shelter in place. So the latent process should be able to pick that up. And so I refer to it often as face mask usage, but it's meant to include all of those distributed behaviors that are reducing transmission from person to person. And so that will also include, for instance, infection barriers, disinfection practices, individual hygiene, all of those kinds of things, which have probably changed both in a systematic way and in unsystematic ways in different populations over time.
I see no further questions if people want to ask, please raise your hand. Otherwise, John, maybe you can just continue with the chat questions for a bit.
I'm gonna. All right, I just pulled up the participant list. So if you raise your hand, I should see it now. I have a question. Is the model or a similar approach being used to model COVID transmission on UGA campus upon reopening? The University of Georgia, like I think every college and university in the country, does have a plan in place. To some extent, it's being informed by information that we're able to collect in real time, and to some extent, it's being informed by policies that are dictated from the state and other authorities. This model is not particularly being used for the University of Georgia, and in fact, I think it would be inappropriate to do so. We formulated the model in a way that we believe is appropriate for a population as large as something like a US state. I think that modeling transmission within an institution or an organization that ranges from something larger than the household level, let's say 100 people, to something smaller than a county, let's say 20,000 people, I think is a real challenge. And we have not engaged in developing any models that we think are appropriate to a population at that size and with the kinds of structures that that brings. So I have a question. Why do you think the SEIR model can simultaneously fit for test positives and death data when we know test data are seriously underestimated? And I probably glided over this a bit too quickly in the presentation. But based on the observation process, our model allows us to stipulate that there is a fraction of cases that eventually become detected, and that the rest of the cases do not. So that's part of the observation process. And moreover, based on the availability of tests, it allows for there to be a changing reporting rate over the course of the epidemic. And so it's our belief that the case notification data do contain information about transmission, particularly on short time scales, because I don't think that test availability is changing much from day to day. And so we think then it's informative to our model. There's a question, can you track the effect of expanding the availability of antivirals? So that would largely come into, I think, the outcomes of cases. And so it might, for instance, feature in the transition from case notification to hospitalization, or from hospitalization to death. We don't have any daily data streams on antiviral availability, so we don't have a way of fitting the model to that. The current version of the model that I'm presented today, also does not allow for that to be time varying. Although, as I said, the crude fatality rate has declined considerably over time. I suspect, I believe that the infection fatality rate has also declined over time due to both demographic causes and changing standard of care. That's not something that's demographically represented in our model, but it's something that we're trying to develop in the next instance. In the next version of the model, when we incorporate this, I don't think it will allow us to say anything particular about, for instance, the causes of the changes in the infection fatality rate, just to estimate crudely what it has been over time. Another question that,
John, sorry to interrupt. I think we've reached the hour already. The time went really fast. There are more questions coming in. We will capture them and send them so that if you feel like it, you could still answer them maybe by email. But at this point, I think I would like to thank John for a wonderful presentation, and the participants, everybody, for participating and for taking the time, and for a great set of questions. And the recording will be available on the MIDAS website. I'll ask John if he's willing to share some of his slides as well. We will have another webinar next week. Oh, not next week, sorry, next month. Let me look at the date. That is going to be August 28th. We'll have Kaja Abbas from London School of Tropical Medicine and Hygiene to talk about the impact of COVID-19 on routine immunizations in low and middle income countries. So I encourage everybody to attend at the end of the next month. And thanks again to John, and thanks everybody else for attending.